to go, then you can just go ahead and click it and you.
Oh. Okay, so I think I am live. Hi everyone, I want to welcome you to NAPNAP's TeamPeds Expert Live. Since July is Juvenile Arthritis Awareness Month, I'm here to talk about juvenile arthritis, which is the most common chronic rheumatic disease in childhood, affecting nearly 300,000 children in the United States. My name is Heather Benham, and I am a pediatric nurse practitioner in pediatric rheumatology at Scottish Rite Hospital in Dallas. And I've been practicing in pediatric rheumatology for 23 years. So I've seen a lot of changes in how we diagnose and treat patients with juvenile arthritis. I'm an active member of both the Association of Rheumatology Professionals, the Interprofessional Division of the American College of Rheumatology, as well as the Childhood Arthritis and Rheumatology Research Alliance. I'm also certified in musculoskeletal ultrasound, which is a skill I use on an almost daily basis in the care of my patients with juvenile arthritis. During my discussion, please feel free to drop questions in the chat, and I can address them during my presentation or at the end of the presentation as well. So let's jump in and talk about juvenile arthritis. So the general diagnostic criteria for juvenile arthritis are the onset of symptoms prior to the age of 16 or at the age of 16, having the presence of arthritis in one or more joints for 6 weeks or longer, and that means it has to be in that particular joint or that set of joints for 6 weeks or longer, and other etiologies have to be excluded. And of course, there are many things that can cause arthritis or swelling in joints. Things like infection, whether that's a local infection to the joint or some sort of systemic infection like Lyme disease, tuberculosis, sexually transmitted infections. Trauma can cause arthritis. Children can also develop a reactive arthritis after infection, so following like an infection with strep or a viral gastroenteritis. You can see arthritis in the context of malignancies. You can see them post-vaccination. And certainly we can also see arthritis as a part of other rheumatologic disorders or other systemic diseases, so things like lupus or inflammatory bowel disease. So really that's part of why the 6 weeks or longer is part of the diagnostic criteria, because this allows us time to identify those other causes, or for some of those causes to sort of fall off the differential before we definitively say that this patient has chronic arthritis. So although we do not know the exact cause of juvenile arthritis, we do know that it's autoimmune in nature. We often term it idiopathic, so you may hear some people refer to it as juvenile arthritis. Some people may refer to it as juvenile idiopathic arthritis, or JIA. So we know that in this disease, the patient's own immune system is attacking their tissues, and the target for that attack is the joints. And we know that these individuals are likely genetically susceptible to develop arthritis. And I try to explain to families that especially to parents, it doesn't mean that you pass something down to your child that caused them to get arthritis. Usually the genetic component is, it's a little bit more complex than that. And then usually there's some sort of environmental trigger. And sometimes we can identify that environmental trigger. We know that the patient had a preceding infection. Stress can be a factor. They can develop a chronic arthritis after vaccination if that arthritis is persistent, but often the trigger is unidentifiable. So when we talk about juvenile arthritis, it's really an umbrella term. So there are many subtypes of arthritis that fall under that umbrella. We've really moved away from calling it juvenile rheumatoid arthritis because only about 5 to 7% of kids have true rheumatoid arthritis, meaning they carry the blood markers that you will see in adult arthritis, and that's including the rheumatoid factor as well as a newer test called a CCP antibody, which actually in adult rheumatoid arthritis has been found to be much more sensitive and specific for that particular diagnosis. So again, we now call it juvenile arthritis or juvenile idiopathic arthritis, because we certainly don't want patients to be missed because labs are drawn and their rheumatoid factor and CCP are negative. So the provider thinks, well, they can't have arthritis because they don't have these markers. But the reality is that most patients with juvenile arthritis don't carry those markers. So the most common age for patients to be diagnosed with juvenile arthritis are between the ages of 1 and 5. We can then see another peak of patients developing juvenile arthritis like after the age of 8 or 9. And we will see some patients present as teenagers. The juvenile arthritis is much more common in females than it is in males, with the exception of a few of the subtypes of arthritis that fall under this umbrella, and we'll talk a little bit about that in just a minute. So we currently make the diagnosis of juvenile arthritis using what's called the ILAR criteria. I've asked NAPNAP to drop a reference into the chat, which talks about the ILAR criteria that we use to make the diagnosis. But those subtypes include oligoarticular juvenile idiopathic arthritis, which are patients that present commonly with 4 joints or less. Usually these patients present with a single knee, or they may have arthritis in 2 knees or an ankle, but really it can be in any joint, but as long as there's 4 joints or less, they are placed into that category. Now, that doesn't mean that these patients will always only have arthritis in 4 or fewer joints. As this patient moves on in their disease process, they can certainly extend beyond that initial set of joints that they may be diagnosed with. We also have a subcategory called polyarticular juvenile idiopathic arthritis, and those are patients that are diagnosed when they present, they have 5 or more joints at the time of diagnosis, but often those patients are presenting with 10 joints, 20 joints, even more than that. Polyarticular JIA is separated into 2 categories. So patients who present with those traditional markers you might see in adult rheumatoid arthritis, so the rheumatoid factor and the CCP, they are labeled seropositive polyarticular juvenile idiopathic arthritis. If they don't carry those markers, then they're diagnosed as seronegative. And again, the patients who have those positive markers are usually only about 5 to 7% of our patients with JIA. There is also a form of juvenile idiopathic arthritis called systemic juvenile idiopathic arthritis, and those are patients who present with arthritis in 1 or more joints and then also have other systemic symptoms that go along with their arthritis. So they'll commonly have daily spiking fevers, evanescent rash. They can develop significant lymphadenopathy, hepatosplenomegaly, serositis, where they can either have like a pericarditis or a pleuritis. And we're going to talk a little bit more about systemic juvenile idiopathic arthritis in a little bit. We also have a subcategory called enthesitis-related arthritis. And this is actually one of the subtypes of arthritis that's actually more common in boys than in girls. I forgot to mention that patients with systemic arthritis, that's actually occurs equally in females and males, typically. So patients with enthesitis-related arthritis, the reason they're placed into this category is when they present not only with arthritis, so swelling in a joint, but they can also develop what's called enthesitis, and that's where you develop inflammation where a tendon or a ligament attaches to the bone. And some of the common places you can see enthesitis are typically about the patella, so where the quadriceps tendon attaches to the superior pole of the patella, where the patellar tendon attaches to the lower pole of the patella, as well as the tibial tuberosity. They can also develop enthesitis where the Achilles tendon attaches to the calcaneus, where the plantar fascia attaches both at the calcaneus and the base of the toes. You can also see enthesitis about the pelvis, so where some of those ligaments and tendons attach there. Um, and again, this subtype of arthritis is more common in boys, usually presenting like around the age of 9 to 12, so kind of in that preteen age range, although they can present as teenagers. The important thing to know about this subtype of arthritis is that they are at high risk for developing sacroiliitis. So that's inflammation in the low back, the sacroiliac joints down there low at the pelvis. When patients develop sacroiliitis, really their subtype of arthritis is equivalent to what you might see in adults, and it's termed ankylosing spondylitis in adults. We also see patients who can develop psoriatic arthritis in the juvenile years. Sometimes this subtype of arthritis is a little bit hard to diagnose because in children, they often develop the arthritis before the skin rash, whereas in adults, they often develop the psoriasis first, and then the arthritis comes later, or they develop psoriasis and arthritis at the same time. So we often suspect psoriatic arthritis in juvenile patients when they present with more of an asymmetric arthritis. So patients who have true polyarticular arthritis, it's often very symmetric. So they have both wrists, both knees, the same fingers on both hands. Patients with psoriatic arthritis tend to have a more asymmetric arthritis. So they might have a wrist on one side and a knee on the other. They can also develop what's called dactylitis, and that's actually where the entire finger or toe becomes swollen. So it kind of looks like a sausage digit is how they describe it. And that's typically because there's not only inflammation in the joints themselves, but there's also inflammation along the tendon sheath of the flexor tendon, either on the back of the finger or the back of the toe. And that can make the entire digit look swollen. Patients with psoriatic arthritis often also have DIP involvement. So that's involvement of like the very farthest joint on your finger. In other types of arthritis, the DIP is often spared. And these patients that we think may develop psoriatic arthritis may have a first-degree relative who has psoriasis or has psoriatic arthritis. So that can also be a clue. And then there's also a category called undifferentiated arthritis, and that's where they don't clearly fit into one category, or they might have characteristics of two or more categories of juvenile arthritis. I will point out that there's been some recent efforts in research to kind of change how we classify juvenile arthritis because it's often difficult when we're transitioning these patients to adult care and what do they call their arthritis when they get into the adult arena. So there's been this push to maybe classify the subtypes of juvenile arthritis that have equivalent types of arthritis on the adult side, as well as identifying the types of arthritis that might be more unique to childhood, just so it makes transition and nomenclature and even obtaining medications from insurance a little bit more smooth. In addition, the diagnostic criteria say onset of disease 16 or earlier, whereas on the adult side, you're diagnosed at 18 or older. So then it's like, what happens to those patients between the ages of 16 and 18? Certainly, we see those patients in our clinic, and we diagnose them and we treat them, but it can be a little bit difficult determining, do we call them juvenile arthritis? Do we call them adult onset arthritis? So that can be a little bit challenging. So let's see, what else do we want to talk about here? Oh, so I wanted to point out that the general diagnostic criteria for juvenile arthritis does not include any lab parameters. And I think it's very important to point that out because there's not a single lab test or a single set of lab tests that we can draw to use to make the diagnosis of arthritis. Now, that doesn't mean that labs aren't an important part of our workup because, of course, obtaining labs is important since juvenile arthritis is a diagnosis of exclusion. So we will use labs to, help us exclude other causes potentially for the arthritis. So that's obtaining things like a CBC, an ESR, a CRP, an albumin, liver enzymes, helping us to sort of delineate, are there something about their cell count that makes us worry that their arthritis is caused by something else? Do they have such significant inflammation that we would be more worried about infection? So certainly labs are important, and we use that as part of differential diagnosis, but they aren't used in and of themselves to make the diagnosis. One of the other things I wanted to point out is because often when we talk about juvenile arthritis, or even when we talk about rheumatologic disorders in general, you may hear about drawing the ANA or the anti-nuclear antibody. So the ANA is actually a group of antibodies that target components around the cell nucleus. But of course, many people hear about the ANA in the context of rheumatologic disorders, particularly something like lupus. But again, the ANA is not used as a diagnostic test. It's not even used as a diagnostic test for lupus. It's really a screening test. And we have juvenile arthritis patients that have positive ANAs, and we have juvenile arthritis patients that don't have positive ANAs. So, and the reality is that 10 to 20% of children can have a positive ANA, particularly if it's a low titer positive ANA. And it doesn't mean anything. It doesn't mean they're going to develop a rheumatologic disorder. It doesn't mean that they're going to develop juvenile idiopathic arthritis. They just happen to carry this antibody. So often we do a lot of reassurance in our clinic regarding this antibody test. The reason testing the ANA is important in the context of juvenile arthritis is that this ANA testing is used prognostically. So this ANA allows us to determine a patient's risk for developing uveitis. So we know that patients with juvenile arthritis can develop uveitis, so that's inflammation in the eye. We don't know why it happens. We don't know why it occurs in the context of juvenile arthritis, but it does. And we know from research that if you carry a positive ANA, it can increase your risk for eye disease. So we have this algorithm that allows us to determine the patient's risk for uveitis. And patients that present young, before the age of 6, they've had disease for less than 4 years, and they carry a positive ANA, they are at the highest risk for uveitis. And often this uveitis is asymptomatic. So the eye is not red, it's not painful, they're not sensitive to light. So it really needs to be picked up by an ophthalmologist. They need to have a comprehensive eye exam, including a slit lamp exam, to pick up this inflammation so that it can be properly treated. But again, that's how we use the ANA in the context of juvenile arthritis. And of course, it's very important to appropriately treat uveitis because certainly uveitis can lead to permanent or to eye damage, which can then lead to permanent eye loss or eye vision loss. We talked previously about the rheumatoid factor and the CCP. And of course, again, once we've made the diagnosis of juvenile arthritis, it is important to know whether the patient has a rheumatoid factor or a CCP, because these factors do put the patient at higher risk for more aggressive disease. We know that the patients that carry these factors in their blood, their disease is more likely to cause erosion to the bone, to cause permanent joint damage. These patients can also have more recalcitrant disease that's more difficult to treat. So it's definitely important to know whether the patient carries these factors or not. We will also check an HLA-B27. I did not mention this earlier, but this is a gene test. It's not a diagnostic test. It's what we call a prognostic indicator. But patients who have enthesitis-related arthritis, develop sacroiliitis, have psoriatic arthritis, can carry this gene marker. So it can increase risk for those diseases, although this gene is also present in about 8% of the Caucasian population who never go on to develop these disorders. I often tell families that making the diagnosis of juvenile arthritis is like a puzzle. So we're putting all these pieces of the puzzle together, and we're using all this information to make the diagnosis. And although labs are important, again, they can't necessarily help us say, yes, you have arthritis, or no, you don't have arthritis. But these factors are important for helping us determine what subtype of arthritis you may have and what risks you may be at, including uveitis or developing psoriasis along with your arthritis, or potentially developing sacroiliitis. So typically, when we see a patient in our clinic and there is concern that the patient has chronic arthritis, we will draw, as our typical arthritis panel will be to check an ANA, a rheumatoid factor, a CCP, and an HLA-B27. Because again, those factors are going to help us determine what subtype of arthritis you have and what risk factors you may be at in association with your arthritis. Okay, so now that we've kind of talked about the diagnosis, we've talked about how we utilize labs, I'm going to talk really briefly about treatment. I know we don't have a ton of time left, but wanted to point out that juvenile arthritis is a chronic disease. We cannot cure juvenile arthritis, but our goal is to put juvenile arthritis into remission. And really, with the medications we have now, I mean, I remember what it was like 23 years ago when I first started in this specialty, and we didn't have all the medications that we have now. I would still see patients that ended up in wheelchairs or needed early joint replacements. And those are the complications that, we are trying to prevent. So really our goal is remission. And that may mean we have to get the patient into what we term a medicated remission. There are possibilities that the patient can achieve what's called an unmedicated remission, where we are able to treat them for a period of time, get them into remission, see them maintain a medicated remission, potentially get them off medication. But we explain to the families that, it's a chronic disease. The nature of arthritis is that it can remit and flare. And even if we can get patients into an unmedicated remission, it doesn't necessarily mean that they can maintain an unmedicated remission. So if they flare, we may have to put them back on medication. So in JA patients that have limited arthritis, such as like a single knee or just a couple of joints, we may be able to treat them with NSAIDs like ibuprofen, naproxen, or we may be able to do steroid injections, and that may be helpful for their arthritis. However, if we can't get the arthritis under control with NSAIDs or steroid injections, or they present with significant arthritis, then we're definitely going to be talking about systemic therapies. And typically the medication that we start with is methotrexate. So, I often counsel families that, if you go and read about this medication, it can be scary. It's a chemotherapy. It's used to treat cancer, but in cancer they use very, very high doses. In arthritis, we're using very small doses once a week, and it really acts as a potent anti-inflammatory. Although it can modulate the immune system, it's not considered to be significantly immunosuppressive, although we do counsel about how to handle the medication if you have an active infection. This medication can be given orally, or it can be given as a subcutaneous injection. There's a little debate about which preparation is most effective, but I think we counsel our families about side effects. Again, many of our patients are diagnosed young. It's sometimes hard for them to take oral medication. And so sometimes a subcutaneous injection once a week is more, effective for them. It really partly depends on patient preference. In addition, the most common side effects of this medication are nausea, stomach upset, decrease in appetite. So sometimes patients prefer to do a subcutaneous injection because they want to avoid putting the pills into their stomach and potentially exacerbating some of the side effects that they may have. If a patient doesn't completely respond to methotrexate, then we will typically move on to biologic therapies. Some of you may be familiar with some of these medications. So these medications work by blocking inflammatory cytokines that we know patients who have arthritis are making too much of. There's ones that block TNF, IL-6, IL-23, IL-17. So there are a variety of these biologic medications. Once we move beyond methotrexate, most of these medications are either injections or given by IV. So of course, understandably that can be very challenging for a child. But in our clinic, we try to utilize child life to kind of help a patient, not only cope with the diagnosis, but kind of cope with all the medications that they may be requiring. There are some newer oral medications that some of you may have heard of. These are in a class of medications called JAK inhibitors, or they're referred to as JAK-STAT inhibitors. So basically the way these medications work is there are some JAK-STAT enzymes that are in the cell wall. And when the cytokine attaches to the receptor, you need these enzymes to help process that signal from outside the cell to inside the cell. So these JAK inhibitors work by blocking those enzymes. Again, they are given orally. There's currently only 2 that are approved in pediatric use, and that is tofacitinib and upadacitinib. The issue with these medications is that they're daily or twice daily. So even that can be challenging for a child, having to take medications, that frequently. If patients have severe arthritis or they already have evidence for joint damage, so erosive disease or joint space narrowing, they have involvement of what we consider high-risk joints. So they have involvement of their C-spine, they have involvement of their TMJ, they have involvement in their low back or their hip. We may actually start them on multiple medications at the same time. So they may start on both methotrexate and a biologic, or methotrexate and a JAK inhibitor. Because really our goal is to get the arthritis in remission as quickly as we can, to prevent joint damage, or if they already have some joint damage at baseline, to prevent further joint damage. One of the medications that I didn't really mention yet is steroids. So I will tell you, in the treatment of juvenile idiopathic arthritis, we really try to avoid steroids. Of course, as we all know, steroids can have a lot of side effects long term, especially in children, right? They can affect growth. They can affect the health of the bone, leading to osteopenia. They can cause weight gain. They can cause acne. They can affect with our glucose levels and potentially, cause complications like diabetes. So we really try to avoid steroids as long-term treatment for juvenile arthritis. We may use a short course of oral steroids early on in the disease if the patient is very symptomatic and we know that it may take time for these medications to take full effect, the medications that we're prescribing. But we usually use a very short course of what we call bridging steroids, and we try to taper those steroids, as quickly as we possibly can. I just wanted to let you know that I did give NAPNAP some resources to kind of drop in the chat. That includes some of the treatment guidelines through the American College of Rheumatology, which kind of goes over not only some of these diagnoses, but also some of the treatments that we use, how we use them, not only for different subtypes of juvenile arthritis, but there's also a treatment guidelines for specifically for JIA-associated uveitis. And then also some resources for the Arthritis Foundation, and through CARA, which is the Childhood Arthritis and Rheumatology Research Alliance. I did, and I forgot that I briefly wanted to mention, I said I was going to go talk about systemic juvenile idiopathic arthritis. I just wanted to mention that subtype of arthritis really quickly because it's a little bit different than some of our other subtypes. So most of the subtypes of juvenile arthritis are really considered autoimmune, meaning there's some sort of abnormality in the cell-mediated part of the immune system, the part of the immune system that makes antibody. Systemic juvenile idiopathic arthritis is really now what we consider autoinflammatory. So patients who develop systemic juvenile idiopathic arthritis have defects in the innate immune system, And that's sort of our immediate defenses of our immune system. But because the defects are in the innate immune system, these patients can develop really significant levels of inflammation. So that's why these patients, in addition to arthritis, develop fevers, they develop lymphadenopathy, they develop hepatosplenomegaly. Um, uh, and we've really learned from research on these patients that the pathophysiology behind systemic arthritis is very different from our other subtypes of arthritis. And that's also changed how we treat systemic arthritis. So we actually target cytokines that are much more common to the innate part of the immune system, which includes IL-1 and IL-6. This is a subtype of arthritis where we may have to use a little bit more steroid than we do in other subtypes of arthritis, because these patients are also at high risk for a complication called macrophage activation syndrome. And that is where they get such high levels of systemic arthritis that the macrophages attack their bone marrow. So they get cytopenic, they can get coagulopathies, they can get liver injury, they can develop CNS manifestations. When these patients develop macrophage activation syndrome, they're often very ill. They have to be in the hospital. They're often in the ICU. So, and there are some things in their labs that we can monitor over time to see if they may be at risk for MAS to try to catch it early. Patients with systemic juvenile idiopathic arthritis are also at high risk for developing interstitial lung disease, which is unique to that subtype of juvenile arthritis. So that's something we also have to keep an eye out for and evaluate for if we see things from their clinical exam that we might be worried about, or symptoms that they might be describing, like they're developing chest pain or shortness of breath. They sometimes develop clubbing of the fingernails, which can be a clue. So I just wanted to bring up that subtype just because of those increased risk factors. So I think that completes kind of our deep dive into juvenile arthritis. It certainly was a lot of information, but again, I hope that the resources that NAPNAP has provided to you in the chat will be helpful. I'm happy to address, if there's any questions that have come up during the presentation. I'm happy to address them. I'm also going to put my email in the chat. So if anybody wants to reach out to me offline, if they have questions about juvenile arthritis, I'm happy for you to reach out to me. I hope that in whatever communities that you guys are in, that you've been able to identify who some of your pediatric rheumatologists are in the community, because, we're a small, tight-knit group, and we're really happy to help if there are ever questions about patients that you might be worried about, that you think, hey, I'm worried about this symptom, should I refer them to pediatric rheumatology? We're all very welcoming, and we'd be happy for you to reach out by phone or email, to ask us what our thoughts are. So we'll just see now if there's any, questions or comments. Well, I don't see that there's any questions or comments coming through. Maybe I'll just wait a couple more minutes to see. And I think someone asked the question, whether this video will be available after the fact, and I think it will on the NAPNAP website. So, all right. Well, it was my pleasure to talk to you guys about JA. And again, I hope if you have any questions or concerns that you'll reach out. Thanks a lot.